Thanks, Michaela. As Michaela said, I just wanted to present to you our study over the last 2 years of an impact of an OT advanced practice clinic for waitlisted orthopedic and plastics patients with hand and wrist pathology. And I'm presenting this on behalf of my colleagues, clinical specialist colleagues, Neve Feeney and Olga Hill, who worked with me on this project, and our two consultants, Catherine Basu, orthopedic consultant, and Marliese Dempsey. So the clinical driver for this initiative was backed on the success of the carpal tunnel clinic in 2017. And that really demonstrated the effectiveness of a triage and treat service for waitlisted plastic surgery patients with carpal tunnel syndrome. Okay. Right, we'll skip that one. We've already talked about that one, so we'll move on. Okay, so as I said, the service review in 2017 of waitlisted orthopedic patients in St James Hospital showed that 579 patients were waitlisted between 12 and 36 months for a consultant appointment. So based on the carpal tunnel pathway, and in line with the HSE strategy of 2016 and 2020 for integrated outpatient services, in October of 2018, we commenced a new initiative to triage, assess and treat elective orthopedic patients with specific hand and wrist pathology. So the aims of this study was to reduce the number of GP referrals waitlisted for the consultant, orthopedic surgeon, to try and provide a streamlined patient pathway from point of referral from the GP to the healthcare provider, which would result in reduced wait times for assessment and intervention. And also to demonstrate the effectiveness of an OT advanced role in the delivery of care requiring autonomous practice, complex decision-making for elective patients with hand and wrist pathology. So our methodology, so of the 579 GP letters, so the waitlisted patients for the orthopedics, they were all triaged, and 201, just 34%, were identified as meeting the criteria for our clinic. We put a business case together and presented this to the hospital management and to the National Treatment Purchase Fund. Funding was agreed by the NTPF based on the assessment and treatment of 10 new patients per week, and this was sufficient monies per patient to bring in and support one whole-time equivalent clinical specialist OT for 6 months. So our inclusion criteria, so any hand and wrist pathology suitable for orthopedic management in the first instance, supported by the orthopedic consultant, also from looking at our diagnostic groups, and we also looked at the current literature. So the conditions that we selected on this basis was carpal tunnel syndrome, cubital tunnel, trigger finger de Quervain's, intersection syndrome, CMCOA, ganglion cysts, Dupuytren's, and lateral epicondylitis. So clinical pathways and screening assessment forms were developed for each condition based on the most recent clinical evidence, and they were developed by the whole hand therapy team here in James's, so it was a good body of work. And we developed, this is sort of an example of one of our pathways and one of our screening assessment forms. Our screening assessment forms are not up on electronic patient records yet, only one of them is, but they're paper documents. So the phase 1 commenced in October. This was the long waiters. So we had 2 advanced practice OTs practicing as hand therapists were identified to deliver the service. We had no additional clerical support, and there's a huge body of clerical work to be done in terms of scheduling, taking patients down off the hospital waiting list, rescheduling, posting letters. But we had great support, and this is a really good link for the NTPF within St James's Cora Carey in the CEO's office, an invaluable link in understanding the NTPF and how they work and what they're looking for in terms of information. So the waiting list numbers were reduced within 6 months by 201. So the 201 that we'd identified were dealt with in that timeline. So 10 new patients that were going to be assessed and treated per week were either going to be referred to the consultant, kept with OT, or sent for discharged altogether. So 3 pathways: discharge, OT review, or back to the consultant for injection or surgery. So having completed the first phase, which was the first 6 months, we then moved on to phase 2, which started in May 2019. The NTPF agreed to extend our funding for a further 6 months. So that meant that all new referrals hitting the hospital were identified with the same wrist and hand pathologies were going to be seen within 4 weeks of receipt of referral. So in July 2019, so within a few months, we reapplied again to the NTPF for increased cost per patient, and this was to absorb the cancellations and DNAs that we had encountered. And we also decided to try and include plastics patients with the same criteria, and this was all agreed by NTPF. So within the first year, by October 2019, with a new business case in, and based on the number of new referrals we were getting through, we estimated that about 11 patients per month would be between orthopedics and plastics would be seen with a new cost per patient, which would support 0.4 of a whole-time equivalent clinical specialist OT. And again, this was agreed for another year. So if we look at the results for those first 2 years, 400 patients were seen between orthopedics and plastics, with a high percentage coming from orthopedics because obviously the service started there. Reason for referral, fairly even across both specialties. So again, carpal tunnel syndrome, gangling, and trigger finger being the higher diagnostic groups. And then we have a mixed bag of other, which could have been anything from soft tissue injuries, wrist injuries, small joint, long-standing injuries that hadn't been dealt with. And so our patient demographics, we had 40%, 162 males, 238 female, with a mean age of 58 and an age range from 17 to 93. So when we look at the outcomes across the 2 years with 400 patients, so in the first visit, 35% were discharged back to the GP, 45% for further OT review, and 20% were discharged to the consultant. At 3-month review, this had changed by increasing by 53% being discharged to the GP, 15% for OT, ongoing OT review, and 32% for the consultant. And at final visit, so our final review was 60% of all patients were discharged, 3% continued with OT, and only 37% were referred to the consultant. This is just the same details, so 60% of all patients. And it's interesting, whether the first year or the second year, the same percentage existed, so 60% of all patients were discharged. So if we look at the diagnostic groups of discharge to the surgeon, as one might expect, carpal tunnel syndrome being sort of the highest number, again, referring to either injection or surgery. Ganglion, trigger finger, again, were high, 3 highest groups. So our KPIs, so all new referrals seen within 4 weeks, DNA sitting at around 20%. NTPF continued the funding for a further year into 2021. And we're seeing about 11 to 16 new patients per month and 12 return patients per month. And those would be our numbers. We have 2 clinics a week, 1 new and 1 review. And all GPs receive a follow-up letter of intervention or discharge. So we completed a quick satisfaction survey retrospectively of our patients, with 7 out of 10 feeling that the quality of the care was good or excellent. We didn't have a massive response given that it was retrospective, but those that did, 9 out of 10 believed the therapist gave sufficient time, was thorough. 80% of patients reported the OT explained the conditions and they understood the treatment prescribed, and 87% were no longer seeing OT. And just briefly, I'm just conscious of time, phase 3 started in 2021. So we introduced the MediRacer for nerve conduction studies. Olga Hill completed the RCSI upper limb injection course, and we applied the same model of care to rheumatology witness and have secured a post for a year on the back of that. MediRacer is a portable nerve conduction machine which was purchased. The 3 of us are all trained now in assessment of patients, and we've set a pathway with specific criteria, and our first clinic commenced in 2021. Our injection clinic started for a number of months now, since May. Olga does a clinic with the orthopedic consultant and one with the plastic surgeon, focusing on trigger fingers, with 17 patients seen to date. And you can see that some of their mixed bag of long waiters and those who are new patients within 4 weeks. So in terms of the injection clinic for trigger fingers removes patients from the consultant list. So we're taking a further 4% away from the consultant. It positively impacts on waiting times and the conversion rates to surgery, and that's well evidenced in the literature. It's a quicker delivery of injection for patients where they might have been waiting a number of months. And the evidence supports patients being seen within 6 months of developing trigger finger, resulting in more likely resolution of symptoms and improved quality of life and function. So just to conclude, the OT advanced practice model of care is safe and effective in significantly reducing hospital elective orthopedics and plastic outpatient wait lists, with 60% of patients, as I said, being discharged back in the community, having been assessed and treated by the OT. Patients report a high level of satisfaction. We have, as I say, our injection clinic up and running and our nerve conduction study up and running. But, ongoing evaluation and focusing on patient outcomes is required. Thank you very much.
Thank you, Michelle. that was fantastic. There's a lot of years of work that went into that. Absolutely. Can I just ask one question from myself, and I'm sure there'll be others, but the MediRacer, is that being used in any other hospitals?
I don't know that it is. I don't know the answer to that. I don't think so. We had our training through, where were we through Norway. It was online. We picked it up through a company that I think one of the consultants actually became aware of it. So yeah, we just happened to get funding through the foundation grants. It took us a while just to get things up and running, but we have a very specific pathway set up for when we would use it, how we do it. It's a big cost you incur for every electrode that you use. It comes with a cost of €35, so it's not for everybody if you've got a lot of numbers coming through. But again, with a year waiting list for patients, and if you've those that maybe they're differential diagnosis, you're not quite sure, it's a good way of validating that diagnosis as well.
Yeah, and it's very accurate compared to the standard?
It is, and you also have access to an interpretation service online as well, which you can pay for, or if you have a really good relationship with your neurophysiologist, and you can link in with them, and we do have a good relationship, but again, you don't want to step on toes. She's aware we have it, and it's very specifically for carpal tunnel syndrome. But yes, the evidence would be, and we've tried it and assessed it, and it does seem to be fairly accurate, and it's not difficult to use.
Great, thanks. Simone, was there any other questions there for Michelle before we go on?
No, we don't seem to have any other questions in. Anybody got any questions for Michelle? You just type it in the chat box at the end of your screen, or you can actually, because we're at the moment, you can just unmute and ask it straight away.
Sorry, just want to say something. Michelle, what an excellent service, and we're glad that we can utilise your workings here in Beaumont as well, and it's a great actually to be able to progress and advance hand therapy in Ireland. So it's a model for the future for all of our sites, and hopefully we'll all be able to start implementing it in our practice. Thanks, Michelle, it's great work, well done.
Yeah, absolutely.
Thanks.
Thanks, Mary. Well, I guess we'll move on then. So thanks so much, Michelle.
Thank you. Thanks very much, girls.
Thank you. Our second presenter today is Paula Minchin. She's a senior OT and an accredited hand therapist at Taylor University Hospital, and she is going to present today on the development and review of an OT pathway for the conservative management of carpal tunnel syndrome. So thanks, Paula.
Now, can you hear me okay?
Yep, perfect.
Okay, I'll just try to get this started. You can see my screen, yeah.
Yep, that's perfect. Thanks, Paula.
Great. Okay, thanks, Michaela. Okay, so I'm just going to talk to you then about a project that we did within OT around the management of carpal tunnel syndrome. Sorry, I just have to change something here. So the background to this is that within our OT department, carpal tunnel is spanning 3 services: neurology, orthopedics and rheumatology. And what we found is that we had 3 different sort of sub-teams of OT. There was some discrepancy across clinical areas around how we managed them, our timeframes, how quickly we saw them, how long our waiting lists were. So we thought it was an opportunity to look at coming together and a few heads kind of working on the same project. We had identified inefficiency in the waitlist management, and through the Meath Foundation in 2019, we received funding for a pilot project to update and streamline our carpal tunnel syndrome management. So it was really looking at within the OT department, from the time the person is referred to discharge by OT, what can we do to streamline that? It was a 3-month project. We completed it half-time over 6 months, myself and Carl Rafferty OT. And just to say as well that Olga Hill was involved in setting up and applying for the project in the early days as well. So today I'm going to look at outlining the project that we completed to update and streamline the OT management, and then just look at sort of, after the fact, how we reflected on some of the outcomes that we achieved or that we noticed along the way. And it does tie in with some of what Michelle has talked about as well. So our old pathway was based on a 6 to 12 week treatment, where we had no standard timeframes built in. So, you know, I might have brought somebody back after 2 weeks to review them. Somebody else might have left them for 6 weeks. We'd no kind of agreement on that. All our appointments were face-to-face and individual appointments, and this was all completed pre-COVID. So any changes that we made were pre-COVID. There was no specific carpal tunnel assessment forms. While we had some outcome measures and our general initial interviews, we didn't have any carpal tunnel assessments specifically. We were using the Boston Carpal Tunnel Questionnaire, but maybe not consistently, not with 100% of our clients. We had varied educational material, different booklets, different maybe handouts, and with no standard letters per discharge. So patients were often discharged with maybe no information back to the referrer, maybe a letter to the GP, maybe not, maybe a note in the chart, but there was no standard practice around that. So just to give you a context of where our service is at the moment, you can nearly discount the neurology side of it, because I think for most people it's probably orthopedics and rheumatology pathway that we might be more interested in. So I'll just take, for example, in elective orthopedics, the GP refers the person in, they're seen initially by the MSK triage physio service, where they're then, if they need to be referred to OT, when they're finished with OT, they're either discharged from the hospital or they're sent back to the triage service or to the doctors if it was them that referred them. And at that point, they are discussed whether they need to be listed for injection or surgery. So when we look at the efficiency of the pathway, now this is not based on everybody that we saw, but we went back and looked at a handful of charts afterwards to see what kind of timeframes were involved. And from the GP to the triage service, they could be waiting up to 6 months. From them to hand therapy, there could be up to an 18-month wait. And then from hand therapy to being listed for surgery, there could be a 12-month wait. So lots of delays along the way. The aim of our project was to eliminate a 24-month waiting list within OT, to review the evidence-based practice and develop an updated treatment protocol and pathway. And it was really important that after the project, that it was going to be something that was going to be sustainable and possible for us to use, and to support that with documentation that would help to maintain the quality of that service. So we looked at the evidence when we were, and I've just kind of included some of the kind of things, I suppose, that we leaned on. So lots of evidence to say the Boston patient report outcome measure should be used. Dalton in the UK had a model for a carpal tunnel class, an education model, which we also referred to. There was lots of information about, or lots of evidence for the use of splints, and not to use physical signs in isolation as well. So based on that, I suppose the consistent things that we brought into our pathway were that we developed a carpal tunnel specific initial interview that would be used across all 3 areas. This included the Boston Carpal Tunnel Questionnaire, both the symptom and the function part of that. They included Phelan's, Tennell's, the work section of the DASH, the Stoddard assessment, this was what the doctors were using, and subjective outcome, which was new. In terms of conservative treatment, we agreed that there would be a minimum of 6 weeks splinting based on the evidence that we had read, that it would include ADL adaptation, tendon and nerve gliding, and education as a key component. And then discharge outcomes were that the patients were either responders and discharged by OT, or non-responders and back to their referrer for injection or surgery. And some of the key kind of changes along the way, I suppose, were that we developed a monthly carpal tunnel clinic, or a class, where the 3 OTs involved brought 9 patients in. They had their initial phone assessment. So on that one day, they had their group education with time for questions and answers. And on the same day, either before or after their class, they had individual treatment with their therapist and had their splints fitted if required. We brought in a telehealth element so that their initial interview was initially done by phone, and their 2-week check was done by phone, and they were only seen face-to-face at the 6-week mark if that was required. And then specific carpal tunnel documentation, so the assessment form and the discharge report was now like a standard template and was completed for every patient. And then a carpal tunnel education pack, and we used the Versus Arthritis UK carpal tunnel booklet was what we found was the kind of most suitable for us. So I suppose, if I haven't gone into loads of detail about the ins and outs of the assessment. My email address is on the bottom, so I'm very happy to share like any of that information. But what I just wanted to look at now were what were the key outcomes that we noticed or reflected on afterwards, and how they would help to develop the future of the service. So a couple of things. First of all, we started off with 102 suitable patients, 38 declined, we treated 64, we lost 13 along the way, so we ended up with 51 patients. So when we look at that from an administrative point of view, 50% of the people that we were referred did not start or did not complete OT. So we looked at like where are the inefficiencies within the service for that. Based on that, we tried to put improvements in place in the administration list of the waiting list management. So we're trying to get our waiting lists on our patient information system, so there is less of a manual process. We started regular validation of the waiting list, so that either by letter or by phone, it would be validated as to whether the person still needs the appointment, asking people to opt in rather than booking appointments that would then turn into DNAs. We've standardized our letters, and we were posting our outcome measures to some people as well, so they had them done before they came in. We looked at what other HSCPs were doing, how they were managing very large waiting lists, and took some of their techniques as well. And we found that with this, I suppose we took one condition and put maybe 3 therapists together, and found that streamlined management of the conditions allowed quicker input. So this idea of kind of maybe blitzing a condition and trying to work together to get through things quickly. And with our discharge letter, we were hoping for a reduced risk of re-referral, because we left the patient and the GP and the referrer with a very clear report, and really said to the patient, gave them the responsibility, don't let your GP or your doctor refer you back for conservative management, you know, if it hasn't been successful. So when we looked at our discharge outcomes, we found, so if we're saying responders are people that we discharge completely, we found that 37% of people were discharged by OT, and 63% were referred back to their referrer. Now, I suppose I kind of thought, God, like 37%, would it not be more than that? How could we get it more than that? But we looked at Dalton's class model, which was similar to ours. They would have found they had 47% responders. And I know, as Michelle just said, you know, carpal tunnel is the one, I suppose, that's maybe more likely to get converted to injection or surgery. So we looked at is there anything we could do or control to maybe make those responders a little bit higher. So when we looked at our cohort, 85% of our people were describing their symptoms in excess of 2 years. And I think if we had broken it down and asked, were your symptoms over 5 years or over 10 years, we would have got a higher number as well. And when we looked at, compare that to Dalton, their cohort, they would have had 26% of their people over 2 years. So we wondered, did the people with shorter symptoms have a better discharge outcome? So on the left there, you can see the people with symptoms less than 2 years, 43% of them were responders versus 37%. So not a huge change, but like the numbers are so small in that category, I suppose it just begs the question, can we get bigger numbers in that category and see if there is a kind of an increase in that response rate? Tried to get to people sooner. We have, I suppose, implemented increased use of telehealth, and obviously COVID has increased that even further. We've maximised the efficiency of the OT elements, so we're confident that when the person comes in to when they leave us, it's as efficient as possible. And provided, I suppose, these figures have provided a platform for us within the wider MBT and hospital management to say, look, these delays that the people are experiencing may be resulting in poorer outcomes. Subjective outcomes, so we introduced where we would have a standard subjective outcome, so asking the person, you know, do they feel worse, the same, slightly, much better, or are they completely cured? So slightly, 47% said they were slightly or much better. And again, when we looked at our responders, how did 47% who said they were better turn into 37% who we discharged? So part of what we reflected on was the decision to inject or have surgery didn't happen with us. So we discharged them back to their clinic or back to the triage physiotherapist for that decision. So we are, I suppose, proposing that access to that injection or surgical discussion at the time when they complete their hand therapy would have provided more accurate discharge data. Because I know anecdotally there were definitely people who said, look, I'm a bit better, but I wouldn't mind having that discussion as to whether or not I might be suitable for injection or surgery. And we found that the project, we've improved communication with standard discharge reports to help this, I suppose, decision making, and have been able to highlight to hospital management and consultants about the delayed decision making. So in summary, have we completed the aims of the project? Yes, we've got that as efficient as possible. And our recommendation, and based on the information that Michelle has given as well, is that it's pretty obvious that a more cohesive triage and treat model of service delivery would maximise efficiency. Where does that go from here? I suppose it's given us the springboard to have that discussion within the teams. So at the minute, I suppose, between OT, physio, rheumatology, orthopedics, hand surgery service, we're looking at trying to start a pilot of a more cohesive triage and treat, where there's increased quicker access to OT, quicker access to neurophysiology, and quicker access to decision making around injection and surgery. So that's at a proposal stage at this stage. So hopefully we'll have a little bit of more information on that in time. Thanks for listening. Resource that you'd like to share, just drop me an email.
Michaela, you need to unmute.
Thank you, Paula. There was a lot of work in that. So thanks for your time. I guess we'll go to the end, or we ask questions now.
Is anybody with a burning question?
I was just going to ask Paula, oh, actually, will we, yeah, sorry, Una.
No.
I was just going to ask Paula, did you find it difficult, I guess, within the staff that you had to do that project? Or I guess you knew there was a means to an end, that it would give you, I guess, enough evidence to...
Yeah, so like we were funded for a 3-month project, so it was extra staff, I suppose, to do it. Now it certainly didn't end at the end of the project; it's still ongoing, to be honest. But to have the time to put the systems in place, absolutely, it was an investment in the future, I would say. And I didn't actually, I completely forgot to include it, but just, I suppose, since COVID, I suppose our class stopped, and we've just put our carpal tunnel education online on the Tala Hospital YouTube channel as well. So we'll continue with it, and there will be a virtual element then to the education. But yes, it was a huge involvement. It was a huge bank of time for hopefully, you know, future development. But it was funded. It was funded, yes, so it was protected.
Okay, that's great. Thank you, Paula.
Paula, is there a way of when referrals, carpal tunnel syndrome referrals come into the hospital, and they're that first touch by whoever kind of puts them up in a waiting list, can they be bounced directly to OT? Is that a possible future direction?
Yeah, it is. I mean, it's just, I suppose, and it's probably reflective maybe of some of the, you know, the services, I suppose, of the people that are here today, is that currently that goes to triage physiotherapy. So they're the first point of contact. So it's just that then at that point, they're referred to OT. So what we're trying to do is propose that, you know, we will work alongside them to triage at that point and take those people that will benefit from conservative management. It's just the context of the way the service is being delivered at the moment in Tala.
Karina, can you turn off your, can you mute?
Oh,
Karina?
sorry.
Thank
so
you.
sorry.
That's okay.
Thank you very much, Paula. We might go on to the next presenter. So the next presenter is Una McCarrick, and she is a senior OT at Crumlin Children's Hospital. And she's going to be presenting on the trouble with TOTS and stoves. So thank you very much, Una.
Thanks very much, Michaela. Hi to everyone. And yeah, like Michaela said, I work in the National Paediatric Burns and Plastic Surgery Service in Crumlin, and I'm just going to talk to you today about an increasing incidence of palmar contact burns that we are seeing in children presenting to our National Burn Service, the trouble with TOTS and stoves. sorry, just 1 second. Okay. And I would just like to say a huge thank you to my colleagues Orla Daly and Eileen Walsh in Crumlin and now in Vincent's, who were a great assistance in the kind of putting together of this presentation. So just to give you a brief outline, I'm just going to talk briefly about the service we provide in Crumlin from a national perspective. We're a tertiary referral centre, and then talk about trends that we have seen in Irish paediatric burns and trends that we are currently seeing. And I suppose for us from a paediatrics perspective, when is 1% not actually 1% of total body surface area burn? And looking at our numbers in Crumlin to date, compared to the international data on these on this patient cohort, and how we redesigned the patient pathway for this patient cohort to improve service efficiencies and, you know, improve the patient outcomes, and what we're hoping to look at next in terms of future projects, developments and campaigns. So yeah, Children's Health Ireland, or Crumlin, formerly Our Lady's Hospital for Sick Children, we're a tertiary referral centre in the National Paediatric Burns Unit. It's a 6-bedded burns unit alongside a 9-bedded plastic surgery ward serviced by 2 OTs. And I suppose the service comprises, just to put it in context for you, an inpatient burns unit, you know, 4-day-a-week consultant clinics, 5-day-a-week day surgery, an OT kind of / nurse-led dressings clinic that runs 5 days a week, and then a trauma clinic, plastics trauma clinic that runs 7 days a week. So again, in context, in the Royal Children's in Belfast, there's 2 beds in their paediatric burns unit, and in Manchester in the Royal Children's they have 6, and we in Crumlin have 6. So this is what I'm talking about today, palmar contact burns in little hands. So just, I suppose, to give you an overview, we kind of categorize our burns in the under 5s and the over 5s, and 70% of the little kids we see are under the age of 5, and then 30% are over 5, and it's a 65 kind of 35 split between burns and plastics. So what are the primary causes of paediatric burns? Accidents. And how do accidents happen? You know, the Swiss cheese model depicts it really nicely. We have a hazard, and, you know, generally there are barriers and protective layers to prevent that. But for us in our setting, the layers of Swiss cheese align and the gaps align, and, you know, the vulnerability to failure occurs and the accident at that moment in time happens. So, you know, lovely Christmas warm cozy scene here. And yet from our perspective in paediatric burns, we see all of the vulnerability and hazard situations that are present at that moment in time. So, you know, why are children a high risk group for burns? I mean, the World Health Organization classifies burns as the 5th most common cause of non-fatal childhood injuries. And, you know, they have thinner skin, so they sustain deeper burns with the same temperature and exposure time to burn source as adults do. And, you know, we all know they have less perception of danger by nature and by design and by developmental stage. They're meant to be curious and exploratory, but that doesn't do well from a safety perspective. And, you know, they have little control of their environment, and they have less ability to escape a burning situation on their own. So a child's skin will on average burn about 4 times more quickly and deeply than adults at the same temperature, and all you need is about 1 second for a full thickness burn to occur. And you know, the burn severity is influenced by the temperature and the duration of exposure and the anatomical location. So a couple of years ago in Crumlin, they did this fantastic study. It was the first of its kind in Ireland to kind of capture the demographics of paediatric presentations to our burn service. And just to kind of highlight, what they found was that in the under 5s, the primary cause of burns were scalds, the tea, the coffee, the kettle, and then flame burns, and then the contact burns that I'm talking about today. So, you know, in this day and age, still in any paediatric burns unit generally worldwide, this is our bread and butter. However, we have now seen in Crumlin a shift in the last 2 to 3 years, and contact burns are now the 2nd most common cause of paediatric burns presentations to our unit. And just out of interest, in the over 5s, they found the flame burns were the primary cause, and then scalds, and then contact burns. So I suppose we've been conscious of these for the last couple of years, and we're conscious that kind of glass fronted stoves and fireplaces, which I'm talking about today, are on the rise. They're more efficient and they're more effective. So we kind of conducted a kind of a national survey of queries with companies that sell these the last while in OT, to look at, I suppose, to look at a picture of how many people buy fire guards with them, how hot the glass can be to touch, and I suppose to get a really clear understanding of the safety mandates and directives that accompany the purchasing of these. And I have to say, the vendors were really keen to talk to us. They were really open and really helpful. And these are just a few snippets of what they told us. So you can see that the glass can become as hot as 700 degrees Celsius within about 10 minutes of being lit. And actually, a lot of them can become hotter than that. And you can see here, one of the guys was very quick to tell us that, you know, the glass can still be boiling up to 24 hours later. So as an adult, you don't want to touch it, never mind as a child. And the general theme from all of them was that about 5% of customers buy fire guards now, because these things are expensive. The stoves and the fireplaces are expensive. They're meant to look expensive and sleek, and who wants to put a fire guard up in front of them? So that was kind of what we found when we spoke to people. So the American Burn Association runs these brilliant burn prevention poster campaigns, and this one just, I think, depicts really well what we see in Crumlin on a really regular basis, on a weekly basis. And they've even documented there the 1300 degree Fahrenheit or 700 degrees Celsius heat of the glass, and that's what we're seeing coming through our doors. So, we know that the median surface area for a contact burn in children is about 1%. And, the pediatric London writer denotes the hand is about 1.25%. But I suppose for us in peds, from a clinical outcomes perspective, in the growing hand and the growing child, 1% doesn't really equate to the devastating impact that the hand burn can have on function and cosmesis and range of motion. So just to show you, this is a little 13-month-old that put his hand up on the glass of a stove, and this is 3 days after the burn. And in spite of aggressive hand therapy, early intervention, splinting, and scar management once the wound was healed, you can see that 3 months after the contact burn, the consequences of the contracture were just devastating. And we had really good parental kind of support and buy-in, and yet 6 months down the line, our attempts at passive extension were this. So you can see the pull in the middle of the ring and the little fingers. So this child had a full thickness skin graft, and this is the hand kind of 15 months after the burn and 6 months after grafting. And this guy will be in our service until he's 16 and 17 or a little bit more and fully grown. But I suppose it's just to say that in spite of the depth of the burn and in spite of early aggressive splinting and therapy, these burns can just have absolutely life-changing and devastating consequences. I apologize here for the quality of the photos. With cyber attack, I had to dig deep into the recesses to rescue these. But anyway, you can see from a timeline here, day 1, 5, 13, and 27. Again, hand to the glass of a stove. And unfortunately, I don't have the most recent photo of this guy when he was in, but he's had one release so far, and again, will remain with our service until we are happy that we have, maintained the stretch in the skin and the anatomy as much as possible. So not to say they're all as devastating as the previous ones. This is a little 16-month-old girl who put her hand up to the glass of the stove a couple of weeks ago, and this is 4 weeks after the Palmer, the Palmer burn, and she maintains her splints at night, and her parents are very good in scar management program, and she's actually doing really well, and hopefully, she will be in the better category. So I suppose, look, our goals are the same as any burns OTs, around preserving function, protecting the anatomical structures and preventing contracture. And we have, kind of a series of roles, I suppose, to play, in our roles, and our tools and our interventions are weighted at different points in stages of burn recovery. But for us in paediatrics, it's just to really highlight that parental education, the one in purple, and buy-in and understanding and trust are so critical to everything we do, because 1-year-olds can't, follow a treatment program or a protocol or engage in their own therapy. So the investment of the parents is key to everything we do. We need them to do the work at home for us. So these are 2 of our little contact burns in their splints, and we all know that children are Houdinis at getting in and out of situations, and as such they're Houdinis at getting in and out of splints. So we need to be kind of extra super Houdinis and wizards in Crumlin at getting the splints to stay in situ and kind of maintain the stretch and the passive range of motion as much as possible. So they're heavily engaged in a really comprehensive scar management program, including the Jope garments, and you can see the little gloves in the kind of the midsection there. So I suppose, like, internationally, the first paper on the burns from glass fronted fireplaces was published in 1998 in Canada, and there was a series of kind of case studies and reports out of North America and Canada the last couple of years. But you can see the recurring theme around the median age being anywhere kind of from 1 to 14.5 months, and the total body surface area being around the 1% mark. And that's what we find. That's what we have found in Crumlin. So the median total body surface area is about 1%, and the mean age is about 13 months, and 60% of these are all deep partial or full thickness that present to us. So they all require hand therapy for an extended period of time. But where we're really concerned now is that in the last kind of 2 to 3 years, there's been a doubling in the numbers. So we're seeing far more than we were seeing, and the burns, 60% are deep. So they're requiring a huge amount of therapy and investment, and I suppose they're putting a huge demand and strain on the health service in general. So I suppose just to talk briefly about, we revised our pathway for these patients a couple of years ago. I suppose there was a pre-existing pathway with kind of numerous steps in it. Just to highlight, plastics trauma clinic only at the time ran 2 days a week. Any burn greater than partial thickness or greater was being admitted to the burns unit and put into these kind of flamazine bags, which are essentially a sandwich bag that goes over the hand with a ton of flamazine in it. And a minimum of a 1 week inpatient stay, but they were an absolute nightmare to splint because, small hands in a sandwich bag, you can just picture it. So we kind of sat down with the team that we work really well with, really collaboratively, and we kind of process mapped the whole pathway from very start to very end. And we were able to identify the gaps and the delays and the kind of deficiencies in the service. And over a period of time and a lot of work and a lot of effort, as anyone, you know, who's kind of revised pathways knows, we have come to this pathway now where plastics trauma runs 7 days a week. We have much earlier access to these kids, like on the day or pretty much within 24 hours. And instead of, I'll just show you here, instead of going into the flamazine bag, they now go into these dry dressing splints, these silver splints, dry dressings and or splints on top of them, but in really small hands and babies' hands, this dry dressing actually holds enough extension for us for the initial few days. So we've kind of revised the pathway now, and they're managed primarily as outpatients by occupational therapy and nursing until they're healed. And then we take over along with plastics. So that has been a lot of work. So I suppose for us going forward now, you know, this is an increasing trend. We need to watch it really, really closely. And we're hoping now to capture all our data over the next couple of years and compile kind of really comprehensive demographics around the kind of the Irish paediatric population and look at our outcomes, like really clearly look at our outcomes. And I suppose just to say that in spite of early aggressive hand therapy and, you know, sometimes with the deeper burns, you know, they may still require release, but I suppose to look at how many surgical releases are required. So we're trying to capture all of that as we go forward in the next couple of years. And we're looking to kind of, I suppose, really highlight the critical role of therapy at the earliest stages. And we're kind of negotiating with different organizations around the country around safety awareness and safety campaigns. You know, we know that these stoves and glass fronted fireplaces are on the increase, they're on the rise, they're far more efficient. So we need to kind of accommodate and work with that. And the Health and Safety Authority, we're looking at kind of engaging with them on a consultative process around standards and mandates and directives. And I'm really keen to kind of establish a paediatric burn incident registry. We don't have that yet for any really cohort of patients, but particularly this cohort of patients at the moment. So that's all a work in progress, and that's to do. So I suppose the take-home message is just, you know, as we all know, clearly defined and mutually agreed MDT pathways, particularly for the little ones, and the importance of early hand therapy. And for us in paediatrics, you know, we could sing it from the rooftops. Parental education, investment of parents, and the buy-in from parents is critical to everything we do. And I suppose protect the kids. So just to say thank you. This is a brief overview for you of our role.
Una, thanks so much. That was really interesting talk, especially because a lot of us probably aren't with the paediatric population. But sorry, if I'm wrong, but sorry if I didn't actually pick it up. How soon after the burn would OT see them? I know you were saying it's a 7-day.
Like within, if on the day or, you know, on the day or the next day, we get them now. We sit on these kids, we get them as quickly as we can. And that's why the revision of the plastics trauma clinic to 7 days a week has allowed us the earliest possible access to them. And we were kind of heavily invested in getting all of that set up at the get-go. So, you know, day 1 or day 2, they can't be left for long because they're tiny little hands and we have to get them as quickly as we can.
Do you have a 7-day service, or is it if they're in on a
Sunday? No, we have a 5-day service. So, I mean, I suppose if it occurs on a Saturday or Sunday, the agreement now is that they come back in on a Monday, and we get our hands on them. Yeah, and that's the agreement. Pardon the pun. Yeah.
How many therapy sessions on average would you say? I mean, I know it's hard to.
Yeah, it's kind of hard to quantify, and that's what we're hoping to do comprehensively down the line. I mean, it depends on the depth of the burn, and it depends how quickly the burn heals. And I suppose it does depend on the parental involvement. But, you know, the deep partial thickness and the full thickness burns, you know, the more serious ones, I mean, you are looking at, you know, we sit on these kids, you know, once, twice a week, depending on geographic location, I suppose. But, you know, thereafter, when they're engaged in a scar management program, you know, we try to keep it really frequent to kind of keep repeating the message of importance to the parents. So it's a lot of therapy time. And once, you know, we are clear that there's an understanding and that there's a plateau, then we can, you know, pull back and give our time somewhere else. But we know from experience, and we know from the literature, we know from the kind of studies that the earlier we get to these kids and the more frequent we see them in the early stages, the better the outcome long term.
Una, does this not, with Crumlin's ties with the Late Late Show and the Late Late Toy Show, does this not scream like 30 seconds at either the beginning or the end of the toy show?
Yeah, we're you know, I suppose the caveat is like I'm a fan of glass fronted stoves and fireplaces. I don't detest them. It's just that from our perspective, you know, I think that's what we're looking at. I suppose we should be really careful because you know, it's a very small percentage of the population in actual fact, but actually the consequences can be life changing, literally. But I mean, when we were talking to the vendors, they were actually so interesting and literally said, I mean, in actual fact, they sort of said maybe 5% buy the fire guards. Who wants a fire guard? It doesn't look nice in your house. You know, if you've spent like a lot of money on this fire guard. So yeah, it's a fine line, it's a fine balance, but like the burns are very severe, you know, and literally 1 second, that's all you're talking about.
Gosh, yeah.
Anyway, thanks very much.
That's great, Una. Thank you very much. Sure, we'll go on to the our fourth presentation today, which is going to be Gillian Gavigan. She is a clinical specialist OT in Beaumont Hospital, and she's going to be presenting on the multidisciplinary trauma assessment clinic, an alternative pathway of care. Thanks very much, Gillian.
Thanks, Michaela. Good afternoon, everybody. Happy Friday. So I am presenting today, as Michaela introduced, on the multidisciplinary trauma assessment clinic in Beaumont Hospital. So just a brief introduction as to the different clinical areas that we cover within our hand therapy service. So ED, orthopedics, plastics, rheumatology and neurology. So the ED service previously was the only direct access pathway to therapy or to occupational therapy. So the advanced nurse practitioners or medics in ED assess patients and send them directly to us. The orthopedics, plastics and rheumatology, up until a couple of more recent service changes, referrals always came through the consultant-led clinic. So I suppose COVID affected, for many of us, the normal day-to-day running of our personal and professional lives. However, the government mandated restrictions that were imposed on hospital activity also presented a great deal of opportunities for us in terms of service change, as we attempted to mitigate for transmission of the virus whilst continuing to provide appropriate intervention for those who needed it. So the concerted efforts between the disciplines involved, so the orthopedic team, occupational therapy and physiotherapy, led to the development of the trauma assessment clinic in Beaumont. And this is a virtual pathway of streaming patient care. So the purpose of the improvement, so I suppose COVID served as a great impetus for us to change how things worked, but ultimately it came down to kind of 4 key things with what the trauma assessment clinic could achieve for us. So it looked at improving quality and enhancing patient outcomes by providing a direct access pathway for appropriate patients being treated in an evidence-based manner from the get-go, and again reducing the socioeconomic impact of disability and injury, supporting a quicker return to work and hobbies. The trauma assessment clinic improves safety by reducing the number of patients presenting to clinic and reducing unnecessary imaging. So national data would suggest that patients attending orthopedic clinic have 2.6 return visits to clinic, which is 3.6 total visits to an orthopedic clinic. And I don't know if this is the same in other services, but certainly in Beaumont, how the process works, the patient presents to the orthopedic clinic, checks in, the SHO or intern who is kind of sitting at the computer is booking an image based on what that patient is referred with. So if you're referred with a hand injury, it's an x-ray of the right hand, left hand, ankle, it's the same. So there's no clinical assessment that takes place. It's patient presents straight to x-ray and then a clinical assessment. So we also wanted to improve efficiency and reduce the unnecessary steps in the patient journey. So as I mentioned, 3.6 return visits to clinic, 2.6 return visits plus 1 initial visit. And each time a patient presents, an x-ray is ordered for them. I suppose in line with the skill level of the different clinicians that are assessing these patients, a patient may come at 2 weeks for an assessment, 4 weeks, 6 weeks, 8 weeks, 10 weeks, 12 weeks, any variation of that, all or a variation of the above. And we also wanted to improve patient satisfaction and enhancing the patient experience. So a wait in clinic can be anything from 30 minutes to 4 hours. which leads to very disgruntled patients then who presents to occupational therapy for a further wait and a treatment session with us when we're able to see them. So I suppose all of these goals for improvement in the service are kind of supported within Sláinte Care, the Orthopaedic Care Programme, HSE guidelines for improving outpatient care, and more locally in Beaumont Hospital improvement plans. So what is the Trauma Assessment Clinic? So it is a virtual fracture clinic. The multidisciplinary team is present and a virtual patient assessment takes place. So it's a novel care pathway for patients, and it's being increasingly utilised across Irish and UK health systems. And it does highlight and does provide safe, patient-centred, efficient, cost-effective treatment by a multidisciplinary team approach, and that is the primary focus for our service. So how did we go about implementing this service change? So quality improvement methodology was used to underpin the development of the Trauma Assessment Clinic. And many people are probably familiar with the PDSA model of change, and it's evidenced, a well-evidenced model of change and sustaining change and improvement within healthcare settings. So this methodology allowed us to constantly review what was working and what wasn't, and to understand if our changes were improving the quality of care and outcomes for patients. And this is quite important because, a lot of things did happen throughout COVID to change services, but we really wanted to make sure that the change was an improvement rather than changing something for the sake of changing it. So we implemented incremental changes. So we initially started with 1 TAC per week, and that developed to 2, developed to 3, developed to 4, and developed then to a 5-day service once we kind of had buy-in from everybody. And I think the gradual building of this was really important. So we had early adjusters to the service change, and we had a few people then that were less keen to adjust to this service change. So giving them a little bit of time to be able to process that this was coming down the road and it was happening, and to be able to, I suppose, flag why it was beneficial and how it was benefiting patient care and indeed reducing the quantity of patients arriving to their clinic. So the key stakeholders involved, or identifying key stakeholders, is a key component of PDSA methodologies and change initiatives. So from the outset, we outlined who the stakeholders were, and this enabled us to really consider everybody who was involved in the patient journey from start in the emergency department through to those present in the orthopaedic clinic. One of the key groups that we did neglect to include was IT, and their really key role in ensuring that we had access to adequate quality of imaging in terms of a proper computer and a proper monitor, along with implementing the electronic referral pathway from the emergency department to the trauma assessment clinic. So the TAC team consists every day of a consultant orthopaedic surgeon, a registrar, now there's an SHO involved, an occupational therapist and a physiotherapist, and unfortunately we don't have nursing involvement at present, but hopefully that will change as we move forward. So I won't reflect too much on this slide in the interest of time, but just to briefly reflect on the types of conditions that are primarily coming through the orthopaedic TAC are metacarpal fractures, carpal fractures, minimally displaced extra or intra-articular digit fractures of a stable configuration, non-displaced distal radius fractures with CMC OA changes or wrist OA changes, and then those kind of inconclusive hand fractures or soft tissue injuries. And I think this has been a really important group of patients to stop ever attending clinic. So the pathway for any patient where it's documented query fracture, they all end up in fracture clinic. But actually when the imaging is reviewed and when the image is reported on by the radiologist and there's no fracture, we stop those patients ever attending there, both the upper limb fractures and the lower limb fractures. So the traditional pathway to occupational therapy from fracture clinic is depicted on the left. So patients would arrive to A&E day 1. They would have their clinic appointment at somewhere between day 5 and day 10, or possibly later, depending on how busy the clinic is. And a patient would often get referred to occupational therapy at week 4 or later. occasionally we would have patients referred a little bit earlier, but that would be very much based on the individual who's assessing them, and maybe somebody who was a little bit more experienced in understanding the role of hand therapy and early mobilization and adequate support. So the TAC, how has the TAC pathway changed this? So patient attends ED day 1, they're discussed on day 2, and a clinical decision is made. So in the case of the wrist, hand or digit injuries, we are aiming to see these patients within 3 to 5 days. So giving them a couple of days for the initial inflammation to subside, so that we can then fabricate the correct orthosis and splinting to immobilize the patient and get them moving in a safe manner. So a really key thing is that if there is an issue, if the patient is not progressing satisfactorily or as we would anticipate with their injury, it's easy for us to book them back into clinic for repeat imaging. And I suppose this means that anytime a patient presents to clinic, it's to add to their clinical journey rather than another step, because that's the way we always did things. So outcomes from July 2020 to August 2021. So there's been over 1,000 patients reviewed, or over 1,000 patients have passed through the trauma assessment clinic. Almost 50 or 44% of the patients have been redirected from the fracture clinic, with 12% of them going to occupational therapy. 93% of the patients who are managed in OT or physio never attend a fracture clinic, and their injury is managed exclusively by the therapist. And of the 56% of patients that do need to go to clinic, 90% of them do not require the next week review as would normally be arranged for them. So you can see on the right hand side, patient feedback has been quite positive, which is one of the key goals of the service. And just to summarise some of the outcomes of the patients that we have seen. So there has been 132 patients assessed and treated in OT. 99% of these required customised splinting. 3 of these patients were referred back to clinic for their acute fracture. 4 of these patients were referred back to clinic for an exacerbation of a previous complaint, which in each case was carpal tunnel syndrome. The average time to the first appointment was 3 days, and the average number of appointments to discharge was 3. So on the right hand side is a graph of the diagnosis that we treat in TAC. So almost 50% of what we see, sorry, my maths is poor, I think it's actually just over 40%, 45% of what we see are the metacarpal fractures. And these, certainly in my experience, are the patients that are referred quite late on with really significant secondary problems. And I would say that since we have been up and running to a 5-day TAC, we very rarely now receive referrals, even for post-op metacarpal fractures at a late stage. The majority we do see now on their first return to clinic. And I think that's been another real bonus of the trauma assessment clinic, is the opportunity to just do kind of the softer, more subtle education with doctors to help them understand the reasons why we see people early, and how being in a splint, engaging in early controlled mobilization is very different to remaining in a back slab or a cast. Okay, and so I suppose just to briefly share with you my insights on what has enabled the success. I think a big thing has been respectfully challenging what the norm is, and I think that's been a really slow process. There are some people who are quite easy to challenge and who respond to you sharing your own experience, or sharing, well, what if we did it this way? What if we try that? And if it doesn't work, this is our backup plan. And that has helped us to kind of get a couple of the consultants over the line for the ones that had a greater deal of trepidation in trusting us. Picking your battles, so pushing a little bit at a time and reading the room, understanding if a consultant is really uncomfortable with the decision, letting it go and maybe tackling it the next time, and sharing a positive feedback story of, oh, this patient was seen and this is what happened and this was their outcome, and it's been a good outcome for them. I suppose the biggest thing is understanding what our role is, and also understanding what the best practice is. You know, because it's not, certainly in Beaumain's case, we have 2 surgeons who have an interest in the upper limb, and for the other surgeons, they do look to us to say, well, what do you think? would this be safe for you to do or not? Ultimately, they make the decision, but I think we need to be in a position to be able to advocate for the patient and to have a good knowledge base of what we're doing. Be flexible. So if you give a little, we'll get a lot more back. One key thing is avoiding taking on all of the admin and making sure that there's a shared responsibility from everybody, and to challenge the dumping in inverted commas of referrals into TAC. So an important part of our TAC is ensuring that we preserve the existing direct access pathways, and that's the case for both OT and physio, and making sure that the path of least resistance is not to refer everything to TAC because maybe the inexperienced team or the inexperienced doctors in ED think that that's a safer pathway for the patient. It's around challenging that and making sure that we keep the pre-existing services up and running. So thank you for your attention, and if anybody has any questions.
So Paula had a question there for you. Paula, I don't know, do you want to unmute and ask the question yourself, or do you want me to ask it for you?
Oh yeah, I can ask. Thanks, Gillian. I was wondering, did you have new TAC, like clinical specialist posts to provide this service, or is this within your current staffing? Was there any allocation or funding for posts?
So initially, when we got started in July, we weren't actually involved initially, and we kind of heard that this was happening and sort of advocated for ourselves and equally advocated for our patients of what our role would be. So for the first 7 months, we did not have any additional staffing. So we just had to find a way to do it, because the only way that we could be involved in it was by proving, I suppose, what our role was and what we added to it. So I kind of was involved with it from the start, and then it was shared across the full team. But from July to February, we had no additional staffing for it. Okay. And we did only get up to a 5-day a week in, I think February, maybe we got to 5 days a week. Initially for the first two or 3 months, it was 1 day a week, and then we went to 2 days. And at that point, I had kind of said to the head orthopedic, surgeon, look, we've shown you what we can do. I didn't say those words, but I expressed to him that we've shown what we can do, we've shown what we can add, but we actually can't stretch ourselves any more than these 2 days. And at that point then, he was very supportive for business cases to look for additional staffing. So we since have a 0.5 whole-time equivalent to serve the trauma assessment clinic service and work on the development piece of that. So at the moment, yeah, we have a 0.5 temporary.
Right, brilliant.
That's a long-winded way of answering your question.
Yeah, no, well done, yeah. Thanks.
And Gillian, when you were saying it's a multidisciplinary team decision, I guess on day 2 when they're actually assessed in the TAC, is that, I know that I guess you were saying all hand injuries and digit and all of that are OT. I guess how is that managed? I know at the moment in our TAC team there's no OT, it's physio, specialist physio, nursing staff and consultant. So I guess they would sort of all talk about the injuries, but I guess just for time saving, you wouldn't be looking at the lower limb injuries. How do you work that, or is it just that who assesses, I guess, the X-ray? And
so the process is we all sit around a computer as we're looking at a screen now. So we sit around the computer, the SHO pulls up all of the images, and we literally go through, okay, this is John had a fall yesterday, ankle, and okay, yeah, that can go to physio, or actually no, we're a bit worried about that needs to go to clinic. So it is literally a conversation around a computer, and the SHO, I suppose, runs the meeting in terms of having the images prepared, the documentation ready, and some of the consultants will want to bring everybody back to clinic, because I guess, and I understand that there's a litigation piece to their post as well, to their roles, and I understand their concern, but kind of a way of kind of taking some of the patients back off them is, well, how about we get started with that and we'll book them for an image in 4 weeks time as a fallback or as a safety net. But the conversation, it all just, okay, this is a lower limb, this is the back, this is the hand, and it just follows in sequence. So For most of the time, our TAC is wrapped up in 7 minutes.
Right, brilliant.
So we could have 5 or 10 patients assessed in 7 minutes, provided it's not, you know, referrals that are completely inappropriate, and then the consultant who happens to be on goes off on a tangent about how ridiculous TAC is and how they should all come to clinic and how could anybody send this referral here? This is totally inappropriate. So I mean, we have moments like that where we just have to nod and get on with things.
Yeah, absolutely, absolutely. No, that's great. It's a lot of work, and as you said, it was something that was happening, and you knew the great role that you could have in it, and you know, did it unstaffed for 7 months, but showed, I guess, the benefit of it.
Yeah, and I think like because I know that there is TAC running in a lot of different sites, and it's, you know, it might be a little bit more challenging to become involved when things are already established. So I suppose we were in a lucky position that we got in at the start. I do think, you know, the dynamic would be a little bit different were we to now come in. I do think it would be a little bit different, but I suppose what we have done is we have developed kind of pathways or standards of care with, you know, along with the upper limb surgeon, and identified what are the red flags for returning back to clinic. So I think that has helped to create more comfort and confidence. But like the majority of the orthopedic consultants now have absolutely, like, there's no issues with taking patients. And I think that they trust us that if there's a problem, we're sending those patients back to clinic.
That's brilliant. Thank you very much, Gillian.
Thank you.
We certainly have TAC and Talon. We've suffered the same problem, Gillian. You know, we're invited. We can show up to any TAC meeting we want to, but it's a real struggle to actually be able to free up people at the same time that a fracture clinic is going on to actually attend the TAC meetings. And we've struggled. You know, if it was at a routine time every day, you know, if they always started the TAC meetings at 8:30 and they ran them from 8:30 to in theory 9, 9:15, it'd be fine. But some of the consultants want to run them at 12 o'clock, some of them want to run them at 10 o'clock. So it is a challenge without dedicated staffing to be actually able to show at TAC meetings. So yeah, and I applaud your ability to get staffing, because we would struggle here to actually get dedicated staffing without using that as a research post.
Yeah, like it's been tricky because, sorry, I know I'm taking a lot of your time, but it is tricky because I suppose the difference between where our funding came from, we're funded by the hospital, and it is challenging when you consider that, you know, our physiotherapy colleagues in TAC are funded by the, you know, by national initiatives, and that's where my colleague who's in the clinical specialist post in physio, so her post is funded that way. You know, but like hopefully that will change, and I know, you know, the data that we are gathering has been shared with I don't know exactly the name of the person, Mary Knott might be able to contribute to that, but you know, our data has been shared by James Walsh, who's our head orthopedic surgeon. So like hopefully it will change. I think, you know, we're lucky, I suppose, that he was very keen to have us involved, and I suppose in terms of freeing up staff, all of our TACs happen in the morning at some time between 8 o'clock and 9 o'clock. So it just means, you know, for a few weeks you didn't get a breakfast. We always take breakfast in the morning, so you kind of just have to go with the flow and be cranky because you didn't get your coffee or whatever. But it's the consultant who's in theatre that day is the consultant that runs the TAC. So that helps to get them in a little bit earlier because they need to get down to theatre. So that helps to keep the time a little bit more consistent, I think. You know, I'm not sure how it runs off on other sites, but I think that has definitely helped us to make ourselves available, because like it's very challenging. And I think the other positive is that when we had no space to run the TAC, I proposed, oh, how about occupational therapy? We've got a lovely big open space. So that has also helped that now everybody comes to our department. So it kind of makes us integral to the process because they use our computer.
That's brilliant.
Okay, thanks a million.
Thank you very much, Julie.